And at that point, it's called an OG tube because it's
sorry.
going through the mouth, guys. Yeah.
Good point.
Good point, indeed. Let's talk about the process.
Like we said, guys, we're cereal today.
We are cereal. Cheers to that. Let's have another drink in between this.
You should have a drink every time we say a full sentence.
Well, we wouldn't make it.
It's about to be cereal with milk pretty soon with this, man.
We're also thinking about a podcast episode to talk about the side effects of alcohol and just kill a quick 6-pack on the show. That's to be determined when that's
Or some more of these.
Or some Jack.
You know, a lot of carbs in a 6-pack of beer.
Yeah.
I'm not sure how much carbs Jack has. We'll tell you for the alcohol episode. We'll break it down for
Exactly.
you guys.
All right. So the process. Usually there's going to be like a diagnosis or somebody's going to be like, okay, we're intubating. And if it's if you're calling a rapid response, then you already know what's going on. The patient's already in respiratory failure. And we're not going to talk about the intubations when the patient just rolls in because that's regular.
Yeah.
So let's talk about just emergent. Usually the intensivist says something's going on. You would see some signs that's saying, hey, we need to intubate and we need to prepare. Depends on what's going on. Usually I like to prepare the room for whoever's intubating, right?
Yeah.
So I'll undo the brakes and I'll push the bed back a little bit, get that set up, and then usually the nurses know what's going on. They could help.
Right.
But if not, we got to gather all the equipment, which we talked about.
Yeah, so if the patient is conscious, you should definitely explain what is going on at first, just so you lay them flat and then bang, they got a tube down their mouth. You want to explain, hey George, we're gonna intubate. You're not doing too good. If they could sign a consent, have them sign a consent, or at least explain what's gonna happen. Be like, hey George,
It's emergent, so more than likely
true
it's
True that. So what you said, move the bed up a little bit so there's some walking room. Remove that headboard, lift the bed up a little bit, like a little bit above the hips, and just so everyone's at a comfortable. There's some short residents or short anesthetists, so they just make them comfortable.
Yeah.
But make the patient comfortable too. Be like, hey, we're gonna give you some medication. You're gonna feel drowsy. You're gonna fall asleep. You might wake up with a tube down your mouth. It might be uncomfortable. Trying to bite down, or you might not even remember us doing this.
Yeah.
But it's gonna be uncomfortable.
Yeah. So you definitely need a respiratory therapist, someone that's in charge of the airway. You're gonna have your intensivist / resident or whoever doctor that's gonna be doing the procedure. I know a girl in Canada. Shout out to you, whoever told me this in Canada. Respiratory therapist intubate. That's awesome. I would definitely love to have one on the show to talk about that. And after that, you need a nurse that probably just is getting supplies, right? And usually a lot of people like to stand by and watch because like, what the heck's going on? And the last person is the person that pushes the meds. Right. And I like to do that a lot. And that's where the rapid sequence intubation kit comes in place. You like to draw up all your meds. Usually I'll ask the doctor before the procedure, hey, what do you like? We're going to talk about the meds, but usually some Versed or fentanyl. I'll draw that up into syringes. So don't forget, guys, you need some saline flushes because you have to push the meds. And you need some empty syringes with some 18-gauge needles, not to waste your time and just pull back right away. And what I like to do is, because you sometimes have 3-4 different kind of meds, usually 3 in the kit, I like to, let's just say, draw back on the medication and then tape the medication to the syringe just so I know what I'm pushing. Because sometimes with all that's going on, you don't know what you're going to push, and sometimes you could push the wrong med.
Yeah, what I like to do with that meds is sometimes I tape them, sometimes I don't. I have them in alphabetical order, so from left to right. So if I have fentanyl Versed, I would fentanyl on the left and a Versed on the right in my hand. And what I also like to have is I also have myself and 2 other nurses. So like Matt said, one is ideal for supplies, but usually they're crowding around you, so there's always a handful of nurses standing out there. But like Matt said, one for the supplies at least, and then one for the meds, and then me as a nurse, since Matt likes pushing meds, I prefer to just look at the vitals. Like, hey, he's sitting down. Let's try this again. Let's extubate him real quick, or move the tube out of there, and I'll give him some few pumps of the bag. Or you just say, hey, he's getting tachy, or he's now an SVT. Let's try and work it, because as an anesthesia person or the resident, their main focus is just the airway. They're just trying to get the YouTube, but they're not looking at the vitals. They're not looking at the pressure. Someone has to look at that stuff. Yeah. Because they can't be looking at everything, because that's too much work for one person.
Yeah, I think they've been pushing for during the rapid response, there's 1 leader. So 1 leader is in charge of the situation, and he's making aware of what should be done. Yeah. Usually sometimes like to wear the tags, and she's the one that's going to be like, okay, guys, hey, he's satting like 60%. Let's bag him a little bit just to kind of let the resident, or say, hey, 40% sats, just so that doctor can make the call, not you.
True.
Same thing if you're pushing the meds, right? You want to be very verbal. Hey, doc, I'm pushing 5 of Versed now. Okay. And he, just so everybody knows what's going on, and not like, oh, I thought you did this. No, I didn't do it. Like everything is verbal. Communication is just flaw.
Yeah, it's gotta be straight verbal. Like you can't assume anything is done. Just like a code, you know, like you can't assume it's been 2 minutes. Someone has to say, hey, it's been 2 minutes, pulse check.
Yeah.
And you can't assume the med's been given or what med's been given. Someone's actually got to say, hey, push in Versed, push in Fent. Because there's no way of telling, and everyone's focused on one specific job, and that's how it's efficient is. Everyone's yelling out what they're doing, but not all at the same time, obviously. And everyone's just focused on their thing. One person looking at vitals, Matt's pushing meds, then anesthesiologist intubating, and then the third nurse is getting a smaller.
And you have those like intubations or rapids that are very, very like unorganized, and you can tell when it's an unexperienced nurse or maybe you're on the floor, and you can tell there's not enough communication, or just someone's not doing this, or you intubated and where's the end title, like what's going on, like and it happens, guys, and that's how you get better as a team or people on your unit, just through these experiences.
Exactly. Yeah, and once they're intubated, maybe they want to throw an A-line in, so you should grab your A-line stuff, have somebody grab it for you, or your central line stuff. And then you also want to make sure that the cuff is inflated, because I've had a few times where the cuff wasn't fully inflated and the ET tube ended up being like dislodged, or not dislodged for me, but I've seen it being dislodged for somebody else. But it's got repositioned, and then the patient's desatting. You're like, damn, I gotta call anesthesia again. And sometimes the cuffs, even though they're not supposed to, they're supposed to work properly, some of them are actually, like popped. Like you try and inflate it and you can't inflate it. So then you got and then you got to extubate and then re-intubate them again.
Yeah, that's my little bedside story about that. And let's not forget, after the ET tube goes in and all the drama happens, we always want to check breath sounds bilaterally. I'll do that always, even though like doctors do it or sometimes ask me. And then always, which is the gold staple, is that chest x-ray. Yep. You want to confirm placement, make sure it's above the carina, right? You don't want it to be in the right stem or something and not ventilating properly.
Right, yeah, and then get your drip set up. Because
that's another one.
You pushed, but there's half on these drugs. They're going to start waking up eventually. Doesn't matter if you give 100 of Fent, for a big guy, he's going to wake up eventually. So
yeah, they're going to start bucking the vent. You're going to hear a bunch of alarms going off. He's going to start waking up, try pulling and, going crazy. And you want to put those little floaties, some people in their ICU, they restrain, just so you're protecting the airway and you're protecting him from extubating himself.
Yeah, usually I just throw them on restraints. Once they're intubated, I just throw them on restraints because you're never really sure how someone's going to react when they start waking up. You might think they're snowed 1 minute and you leave to get something real quick. You come back and they're moving around, they're upside down in the bed. You're like, shit, I should put them on restraints. So you're about to put them on restraints right away and then discontinue them a little bit later on once they start opening their eyes, or they start following commands a little bit. RAS score starts to improve a little bit. Then you can take out the restraints, and then of course if they start thrashing or trying to pull their vent, put the restraints back on. That's what they're for.
And you can't trust your patient. Like they said, they're not going to pull the tube, and they're all sincere on the tube, and you took the floaties out because they'll yank it, man. I had a lady that did it too. She was like 29.